local GI doctor sees this 10-month-old and sees her swollen lymph nodes and blood in her stool. He does an endoscopy and colonoscopy and sees polyps and inflammation and prescribes some anti-inflammatories. At age 2, she's seen by an ENT doctor who takes out her tonsils and adenoids and says she has too many ear infections. At age 3 and 4 and 5 and 6, the infectious disease doctors provide anti-inflammatories, antibiotics, antivirals because of her infections, pneumonia, sepsis, and influenza. They also gave her steroids for years, as you can see in her face. Every specialist sees a piece of her. This 29-year-old woman, infectious disease doctors provided her years and years of antibiotics for pneumonias. Dermatologists struggled to control her recurrent fungal infections of her skin and face and nails. She had chest pain that no one could understand. Family members had recurrent infections. Every specialist saw their piece of her. Then she came to see me. I'm a pediatric immunologist, and for me, these pieces are all part of a bigger puzzle. The puzzle of the immune system and how it touches every cell and every organ in the body underneath it all. When we saw her, she had a bacterial pneumonia. We treated it, but we also took the first real look at her immune system and sequenced her genome. And what we found is that her antibody levels were low, her B cells were non-functional, but she also had a genetic disorder that went undiagnosed for 29 years that was attacking her body and her organs her whole life. As an academic physician scientist, pediatrician scientist, I spend most of my time in the hospital and clinic taking care of patients like this and working with lots of specialists who see patients like this too. These are not unusual stories for me, and I'll share with you what I've learned. The immune system does not respect specialty boundaries. Our patients with immune disorders are found in every clinic of yours. Hematology, gastroenterology, pulmonology, endocrinology. Our patients are in all those clinics hiding with their special disorders. And these specialists are doing the best they can caring for them, for their patients, but they're using what we call tunnel vision. Because in the current medical system, we really focus our doctors and our care on the organs that they're focused on. My career has been built on the idea that if we can find these patients from those clinics and bring them to our clinic, then we can do genetic, molecular, immunologic testing, understand the underpinnings of their diseases, and then treat them with precision medicine. And we like to think that it works, but on the other hand, in the current system, our patients face about a 10-year delay of diagnosis because they're trapped in those clinics. 10 years of symptoms, 10 years of infections, 10 years of organ injury, 10 years of a child and an adult being told by these specialists, in one way or another, that their symptoms don't make sense, that their picture doesn't quite fit into the puzzle. So when will it fit? Where does it fit? How does it fit? It fits when we find the genes and the underlying disorders and pathways, and then we treat them. And we can turn around very, very sick patients dramatically. That's the power of evidence-based, mechanism-based precision medicine. For the last decade, I've been at UCLA as the division chief, and I've been doing this, discovering genes, discovering pathways, but also repurposing drugs from other fields and using them in our patients as targeted precision therapies. The challenge for us is to just find these patients, get them into our clinic, and that's really important before the damage is done. And so that's where my other line of work comes in, funded by an R01 from the NIH and my colleagues at UCLA and at the other UCs you can see here. We use the UC Data Warehouse, which you've heard a lot about, and yes, I'm his brother. We built algorithms to score patients based on their clinical phenotypes, starting with bona fide patients at UCLA and the 5 UCs. We train our method on their labs, their history of infections and autoimmunity, and then try to find other patients, individuals in our health system who are as yet undiagnosed, with the idea that they have a putative immune deficiency disorder. We published this work in Science Translational Medicine in 2024, and we've now implemented it across all the UCs. It works. We find patients about 1 to 4 years earlier than the standard of care previously would have diagnosed them. One of these patients is we found here in Irvine, a 22-year-old woman who had recurrent sinus infections, ear infections, pneumonias. She had utterly absent immunoglobulins when we had her seen in the immunology clinic. Virtually no B cells. 22 years. before she got diagnosed. And when we sequenced her genome, we found a new gene and potentially a whole new genetic disease that has yet been not been diagnosed yet. AI found her, not us. In fact, we humans failed her. We failed her with our tunnel vision, and we may not have found her in time if it weren't possible to have that AI, that machine learning algorithm, actually discover her. And this is unfortunately the truth right now, is that even with these extraordinary efforts, with our incredible capabilities, with world-class expertise that we have here at the University of California, we rarely find these patients. And when we do, we only find the causative genetic disorder for them about 30% of the time. 30% of the time. The molecular complexity of the immune system is too much. The variants of unknown certain significance, polygenic interactions, phenotypic diversity of all of our patients, gene-environment interactions, epigenetics. It exceeds what any one human can hold in their head. And so, AI will pass me, and it'll pass all of us. It will do what I do, and it'll do it better. It will integrate every genomic data set, every published pathway, every clinical record, and it will find genetic linkages and immunological consequences that I haven't thought about. It will interpret genetic tests and biological tests and flag patients who need workup. It will refer them for treatment protocols that we haven't invented yet. It will do what I've spent my entire career doing, and it will do it better. It will do it soon. It will do it in the next few years. I sincerely believe that. A few days ago, an undergrad came to my office and asked me if she should go to medical school. I could not answer this question very quickly, which surprised me. And I sat with the question really, which is, if AI is going to find all these patients and diagnose them and find their new genetic disorders and come up with treatment plans, what am I contributing? What has my humanity been contributing to their patient care? What have I been undervaluing? What am I doing in the room with these patients that an algorithm couldn't do? I've been practicing at major academic medical centers for the past 20 years. So I speak with experience when I tell you that we have made a mess in modern medicine. We have constructed a system where physicians are evaluated by RVUs, billing units that have rewards for procedures and high throughput, but have nothing to do with the patient, what the patient wants or needs, or what society needs. We train residents to suppress their emotions, to project confidence and optimism. And that is good because confidence has real therapeutic value. It helps people feel better about their chances. It activates placebo responses. It holds people together in impossible situations. These are not the wrong instincts, but when you combine these all together, you create a culture where there's no space for physicians to be emotionally present with a family. I speak from experience, my own experience as a patient. And I've learned to leave my own feelings and sensitivity outside the door before we round, because that's what the culture asks for from us. And we train doctors to be transactional, to execute, to order, checklist-driven, guideline-driven care, to write prescriptions, to perform procedures. And that's what the patients come to us for. We are their providers, and they are our customers, not for the relationship that we used to know as doctors. The tunnel vision I talked about earlier is a natural consequence of this transactional world. Eat what you kill, RVU based. There is no ICD code or RVUs given for caring. I have a patient who is a young man who has a serious immune disorder. He has no B cells, no antibodies. He brings his girlfriend to clinic. She tells me that she's the one who provides his medicines. He might be able to manage his medicines himself, but a part of him parentified her because it's the only way he knows how to show love. And a part of him is terrified to be alone with his rare disease. It's the only way that he knew how to maintain connection, and unsurprisingly, she left him. This is not a problem of diagnosis and treatment. This is a problem of a human being trying to survive the isolation and fear of illness. I follow a young woman who told me recently that she has literally nobody to talk to about her fear, about what it feels like to have a body that is attacking itself. She lives in a culture where there's a shame and stigma that's more important than illness. So she became so practiced at performing normalcy to her parents that she was a stranger to her feelings of suffering. And she started crying when I asked her what it was like for her. AI will find these patients in the medical record system. It will interpret their genetics. It will recommend the right treatments for them. But who will sit with them? Who's going to teach them about their diseases? Who's going to help them adapt to their disorders with the knowledge of the immune system and the B cells in their antibodies? So here's what I want to leave you with. AI is going to be extraordinary at performing all the modern, efficient medical system that we've built. It's systematic, evidence-based, algorithmic, genomic, heartless system that we have built. It will do that better than us, and we should let it, and we should do the best we can to build it that way. But we should then free medicine up for what it was meant to be for us. The 29-year-old I told you about in the beginning with a decade of pneumonias, she died about a year or two after we started caring for her. It was too late to alter her trajectory. But she cried when we told her what we discovered about her disease, and she and her mom. Not from relief that she could be cured, there was no cure for her, but she cried because for the first time someone had told her that she was right, that something was wrong. You're not crazy, it's not all in your mind. Your body is actually fighting something real. I didn't give her that answer from a genome or an algorithm. I gave her that answer as a human being who had taken time to spend time with her as a human being. And as AI takes over all the diagnostic work and the burdens that we have become accustomed to as doctors, we have a question that I want to leave with all of you. What are we going to do with all the space that's left? Because someone still has to be in the room with these patients. I think it's time to take back medicine, take back the job that's called being a physician, where we treat patients and treat their bodies with the humanity that they expect from us.